So today I'm going to be talking about the evaluation of a child with joint pain. Musculoskeletal pain is very common in children and adolescents, and up to 30% of children are going to present to care at some point with musculoskeletal pain. So it's very important to have a framework for evaluating these children, not only in primary care and the emergency department, but also in specialty care where conditions like inflammatory bowel disease or migraines may present with musculoskeletal pain as well. So I have no conflicts of interest or disclosures related to this presentation today. And my learning objectives for you all is to be able to distinguish between inflammatory and non-inflammatory musculoskeletal pain based on a child's history, to be familiar with the pediatric gait, arm, limb, and spine musculoskeletal exam, and identify those physical exam findings which are associated with arthritis in particular. And I will review and help you understand the presentations of some common rheumatologic conditions associated with joint pain, including JIA, hypermobility, and amplified musculoskeletal pain syndromes, or so as a rheumatologist, how do I go about distinguishing between arthralgia, which is just pain in a joint space, versus arthritis, where there's actual inflammation in the joint space? And in general, this really can be done by the history and the physical exam alone without the need for imaging or other testing. So when I'm taking a child's history, these are some of the things that I'm going to be paying close attention to that help to distinguish between non-inflammatory pain and arthritis or inflammatory pain. So pain that is worse with physical activity tends to be more associated with mechanical pain, and pain that's associated with prolonged sitting or improved with physical activity is more inflammatory. Now, of course, these are general rules of thumb, and they are not going to be always applicable, but in general, those are the cases. Pain that's worse at the end of the day is typically associated with mechanical pain, and pain that's worse first thing in the morning is more associated with inflammatory pain. Patients with mechanical pain can have morning stiffness, and it's not uncommon for a parent to tell me that their kid walks like a little old lady first thing in the morning, or they have a really hard time getting moving first thing in the morning. But that morning stiffness really should be brief, and if it is longer than 30 minutes, that becomes concerning for an inflammatory cause of the pain as well. And all of these things, pain that's worse with prolonged sitting, worse with physical, or worse with inactivity, worse first thing in the morning, worse with prolonged morning stiffness, those are all due to a kind of gelling phenomenon that happens when there's inflammation in a joint space. The other thing that's important from the history is how often are these kids having pain? Is the pain intermittent or is it persistent? Arthritis is typically going to be a more persistent pain that is getting worse over time. Now, things like amplified musculoskeletal pain syndrome will also have persistent pain, but in general, intermittent pain is less likely to be associated with arthritis. And intermittent swelling is also seen more with mechanical pain versus persistent swelling. So things like hypermobility can have swelling that happens at the end of the day or with physical activity. However, that swelling typically lasts less than 24 to 48 hours and then resolves spontaneously. And swelling that's associated with arthritis is going to be more persistent, lasting for weeks at a time, rather than resolving in such a short. So in addition to the history, the physical exam is really integral to differentiating between both inflammatory and non-inflammatory pain. I want to present to you this exam tool, which is called the Pediatric Gait, Arm, Limb, and Spine exam. This is a set of exam maneuvers that's used to examine the entire musculoskeletal system in a relatively short but comprehensive manner. And then if abnormalities are identified, you can do more detailed examination of the relevant area with inspection, palpation, or range of motion. There is an adult correlate to this exam, which is called the pGALS exam. It's slightly different, but I'm going to review the pediatric version. When performing the pGALS, one of the biggest things that you're going to be looking for on exam are verbal and nonverbal clues of discomfort. So is the child having grimacing? Are they withdrawing? That sort of thing. And it's important to do the full screen, which is really examining every joint kind of head to toe in the body, because the extent of joint involvement may not be obvious from the child's history. And I would say very frequently, actually, I see children that will come in with a swollen knee and knee pain. And that is what both the child and the parents have been focusing on. But because there is intense discomfort in that one joint, it serves as a distractor from what's happening in other joints. And so I may go on to identify that actually there's ankle, finger, neck, other joint involvement. And that really changes your differential diagnosis if there is multiple joints that are involved versus one joint. And so it's important that we're examining head to toe when someone's coming in with abnormalities only in one joint, okay? In addition to the verbal and nonverbal clues of discomfort, you're also going to be looking for asymmetry on exam. So that asymmetry maybe is there obvious joint swelling? Are there differences in muscle bulk, which could be indicative of a more chronic inflammatory process? Is there a difference in range of joint movement from side to side? And that can be subtle. So many kids have some hyperextension of their knees, right? And then if they have inflammation in that knee, they may lose hyperextension on one side and maintain hyperextension on the other side. And that's actually a sign that there's limited range of motion there. And then you, of course, want to consider any clinical patterns. So do they look like they have Marfan's? Do they look like they have hypermobility? Are we noticing scoliosis or leg length discrepancies on their exam? So this here is the pGALS all in one slide. I know there's a lot of text and pictures on this slide, but I wanted to show you what the exam is in its comprehensive form. The exam starts with several screening questions, and those questions are, does your child have any pain or stiffness in their joints, muscles, or back? Does your child have any difficulty getting themselves dressed without any help? And do they have any difficulty going up and down stairs? And then the exam is a series of these composite maneuvers. So many of them are looking at multiple joints at once. The order in which the paper has this exam is not the order in which I typically do it because most children start sitting on the exam table. So I usually start head to toe doing cervical spine, the jaw, the arms first, and then I have them lay down and I do the lower extremity portion, and then I have them stand up and I do what parts of the exam need to be done in a standing manner. I'm not going to go over every single maneuver on this slide. I think you guys can use this for reference after the fact, but there's a few that I do want to draw your attention to. So when we are examining the cervical spine, which is done in this case with this maneuver where they have them reach up, touch the sky, and look at the ceiling all at once, going like this. In children that have cervical neck arthritis, cervical spine arthritis, the first thing that they're going to lose is neck extension. So they're going to have difficulty with that motion there. And that is a sign that there could be arthritis in the neck. And that is different from pain with neck flexion, which is going to be more in these muscles along the cervical spine. That's associated with technology neck, being on our phones and computers too much and looking down. And so that is a very helpful distinguishing maneuver there. Okay. The other thing that I want to remind everyone is that the TMJ is a joint and it can be involved in juvenile arthritis. And so we want to make sure that we're examining that joint when we're doing this exam. And the way to do that is to have children open their mouths to the fullest extent possible and then see if they can fit 3 of their fingers vertically into their own mouth. And that suggests that they have adequate opening there. You also want to look for, is there any jaw deviation when they are opening their jaw? Okay. Many of these other maneuvers we're looking at, do they have full extension, flexion? I think they kind of speak for themselves. The last thing I want to talk about is this forward flexion as well. So many of us are doing this to screen for scoliosis in clinic, but also if there is any sort of Sacroiliitis or ankylosing spondylitis, what those children lose is forward flexion. And rather than bending in a rounded spine, they will bend forward in a fold, like a folding table. So they'll have a flat back rather than a rounded back. And that is a sign of inflammation in the lower spine. So when we are assessing these patients, what are the things that we're looking for that are going to tell us that there's arthritis there rather than just joint pain? So, of course, if there's a joint effusion on palpation, if there's swelling that we can detect on exam, then we're going to know that there's inflammation in that joint. And the other way that we know that there's inflammation in the joint is if there's pain with limited range of motion. So pain alone is not enough to tell us there's inflammation there, but if the range of motion of the joint is actually limited along with pain, then that is concerning for inflammation in the joint. We can also see findings such as redness, warmth, synovial thickening, and chronic changes like leg length discrepancies can be seen as well. These are some examples of findings of arthritis on exam. And so this on the left, this is all pictures of the same child. So she has significant arthritis on her exam. This upper left picture is showing that she has swelling in the midfoot region there. So she has midfoot arthritis. To the right, she has swelling of both of her knees, and she has contractures of those knees, so she is not able to fully extend them. Her jaw, she has limited opening there. You can imagine if she were to try to insert 3 of her fingers that they would not fit in between those teeth there. And she also has some retrognathia. That's a sign of prolonged arthritis in that joint. Here she has swelling of both her elbow and her wrist. She has swelling of multiple toes and fingers as well. This picture of the hands in the upper right shows inflammation in multiple MCPs and PIPs with relative sparing of the DIPs. And that is a pattern which is consistent with rheumatoid factor positive polyarticular arthritis. And this bottom right is showing a single swollen toe. That's dactylitis, which can happen in enthesitis-related arthritis and psoriatic arthritis. That dactylitis or sausage digit is the same finding, which can be seen in patients with sickle cell, but the pathophysiology is different. So in arthritis, what's happening is you're getting inflammation of the tendons in addition to the joint spaces there, and that leads to this appearance of the entire toe being swollen, or the entire finger in the finger. So the reason why it matters, why we care, why we're trying to differentiate between mechanical pain and inflammatory pain is that the differential diagnosis is going to be different, right? And so when we are thinking about causes of non-inflammatory joint pain, that includes mechanical causes of pain like flat feet and hypermobility. It includes some of these orthopedic causes of pain like Osgood-Schlatter's, avascular necrosis, or legs Calvé-Perthes. Of course, amplified musculoskeletal pain syndromes and CRPS can present as joint pain, but they would not have any inflammation on their exam. Trauma can look like pain. And certain vitamin deficiencies, vitamin D, vitamin C, can also be associated with joint pain. And I highlight vitamin C in particular because in patients that are picky eaters or kids that have autism diagnoses, they often have restricted diets that can lead to vitamin C deficiency, and those kids can have a lot of pain from that, and they can actually develop scurvy. And their symptoms resolve with vitamin C supplementation. So it's something that we don't want to miss when we're evaluating those patients in particular. And then when patients have arthritis, our differential is going to be things that cause inflammation. So whenever I'm thinking about things that cause inflammation for my patient population, there are 3 groups of things that do that. The first would be infection, the second would be malignancy, and the third would be autoimmune or rheumatologic causes. That's an oversimplification, but I think that helps when we're coming up with a differential for these patients when there is inflammation. And so when there's inflammation in a joint space, those are the 3 big things that I'm thinking about. And if there is arthritis on history and exam, one of the things that helps us to narrow down that differential is the timeline of symptoms. So more acute presentations, things that have been present or going on for less than 4 weeks, that is going to be more likely infection or post-infectious. Transient synovitis, probably the most common referral that I see for true synovitis, that is going to be existing for anywhere from 1 to 4 weeks. It can persist a little bit longer than that, but it's going to be relatively short in duration, right? Septic arthritis, that's going to be an acute presentation. Those kids are not just out there with chronic septic arthritis for months at a time. As we get into the subacute time frame where symptoms have been present for longer than 4 weeks, acute infection and post-infectious causes become less likely. And we start to think about rheumatologic disease and malignancy as having a higher likelihood in this time frame. And then the longer out we get, the longer these symptoms have been persisting, the more likely that is that this is going to be a rheumatologic disease. With the caveat that if there are chronic symptoms, then there should be chronic changes on physical exam. So if there is true inflammatory joint pain or inflammatory arthritis, then if that's been persistent for months and months and months, there should be chronic changes, meaning we should see joint swelling, we should see limited range of motion, there may be limb length discrepancies, there may be muscle girth differences from side to side. And if there are chronic complaints of pain, but a normal physical exam, so if pain has been going on for more than 6 months and the physical exam is normal, that is very reassuring against everything on this slide. Okay. So today I am going to talk about a few specific diagnoses that are commonly referred to rheumatology for joint pain. And I'm going to start with juvenile idiopathic arthritis. So the diagnostic criteria for juvenile idiopathic arthritis really only consists of two things, and that is arthritis, which is detected by history and physical exam alone, arthritis that is lasting longer than 6 weeks and is presenting before the age of 16. There is no lab testing, there's no imaging criteria. It is simply arthritis that's been present for that length of time. And you have to have excluded alternative diagnoses. The epidemiology of JIA, it presents in about 1 to 20 out of 100,000 children. That depends on the location where these studies are done. It is more common in girls, and the age of presentation is really variable depending upon the subtype. So these are the different subtypes of JIA. I'm going to put a big asterisk in your mind next to systemic JIA, and that's because systemic JIA is unique from the other subtypes of JIA. Systemic JIA is really a disease of the innate immune system. That means it is an autoinflammatory disease. And that's in contrast to these other subtypes of juvenile arthritis, which are disorders of the humoral or adaptive immune system and are autoimmune diseases. And the diagnostic criteria for systemic JIA are also distinct in that you have to have had a fever for at least 2 weeks, along with rash, arthritis, sinusitis, lymphadenopathy, other things. And the inflammation, the fevers and rash, those sorts of things, often precede the development of arthritis in systemic JIA. And so it does not have the criteria of needing arthritis for 6 weeks in order to make that diagnosis of systemic JIA. And its treatment is also distinct from the other subtypes. And really, the naming was done before we understood the pathophysiology of these conditions and that it is really unique. These other subtypes, oligoarticular JIA, polyarticular JIA, they are dependent on how many joints are presenting and where they are presenting. Oligoarticular is the most common. These are going to be typically your toddler girls that present with one swollen knee. They are more likely to be Caucasian, blonde-haired, blue-eyed. And your RF positive polyarticular, patients, those are going to be your teenage girls that have symmetric small joint arthritis and look like your rheumatoid arthritis patients in adulthood. So when we are talking about the evaluation for patients with JIA, the important thing to know is there are no lab tests which are diagnostic of JIA, and there are no lab tests which can rule out the diagnosis. So many children with JIA have completely normal labs. From a primary care emergency room evaluation standpoint, the lab that I would suggest getting on these patients is a CBC and potentially inflammatory markers. The reason for getting a CBC on these patients is that you are ruling out leukemia, and it can also help to think about the differential for these patients. So if there are significant cytopenias, not only are you going to be worried about leukemia, but you may also be worried about lupus. If there's significant anemia, you may be worried about inflammatory bowel disease. Patients with JIA either have normal CBCs or a little bit of leukocytosis and thrombocytosis. Okay, so the CBC is not for the diagnosis of JIA, but to think about other conditions that could present with arthritis. The inflammatory markers also, they can be mildly elevated in JIA, but if they are significantly elevated, especially the ESR, if that's significantly elevated, then I am thinking more about inflammatory bowel disease or lupus rather than JIA. Now, these other labs, which are associated with different subtypes of JIA, they are not helpful for screening for JIA. So the ANA is positive in less than 50% of patients with JIA. So it is not sensitive for it, and it's not specific, right? It can be positive in lupus, thyroid disease. It's present in 20% of healthy children. And so it is not helpful for the diagnosis of JIA. What it is helpful for is within this condition, it predicts the likelihood of the development of uveitis. And patients that have a positive ANA, they are more likely to develop uveitis. And so we have them be screened by ophthalmology more frequently. Similarly, the HLA-B27 allele, this is a risk allele. That means it is associated with an increased risk of developing autoimmune disease, but that risk is fairly low depending on the studies. If you have this allele, between 1% and 5% of people with that allele will develop autoimmune disease. And the allele itself is present in about 5% of the population, so a significant portion of the population. The rheumatoid factor, again, this is associated with certain subtypes of JIA, and what it is helpful for is it can help predict that the disease will be more chronic, that it will be more destructive, and that it's associated with an increased risk of interstitial lung disease. Okay, and we may get a Lyme on these patients depending on their presentation to rule out Lyme arthritis. Imaging of these patients, we can use ultrasound or MRI. Both of them are relatively sensitive for evaluating for arthritis. And then the treatment of JIA, the initial first-line treatment is actually NSAID therapy alone. We do a trial of 6 weeks, and if that's effective, then they only need NSAIDs, but many do need more therapy. That may be intra-articular steroid injections, DMARDs like methotrexate, biologics like Humira, and then physical therapy as an adjunctive therapy. Okay, moving on to talk about joint hypermobility. Now, this is a very, very common finding in the pediatric population. Depending on the study that you look at, up to a third of children and adolescents will have hypermobility. So you're going to see this much more commonly than JIA, which is 1 in 100,000 children, right? It is more prevalent in females and it decreases with age. This is the Baton scoring system, which is used to diagnose generalized joint hypermobility. So that is testing hypermobility of the fifth finger, if it bends backward past 90 degrees, if the thumbs are able to oppose to the forearms on both sides, if the elbows go beyond 10 degrees beyond full extension there, if the knees hyperextend beyond 10 degrees, and are they able to get their hands flat on the floor without bending their knees. Okay. In children and adolescents, a score of 6 is required for this to be positive and for them to be considered to have generalized joint hypermobility. Along with hypermobility, of course, comes this question about hypermobile Ehlers-Danlos syndrome. And so I'm going to touch on this criteria really briefly, but I want to point out that this is adult criteria that was developed for adults. And I'm going to talk a little bit about what do we do with children with hypermobility in a second. But in order to be diagnosed as hypermobile Ehlers-Danlos syndrome in adults, you have to have generalized joint hypermobility. That's the first criterion here. And then within the second criterion, you have to have 2 out of the 3 possible features that are here. And the first feature is having a number of skin and soft tissue and other connective tissue abnormalities that can be associated with hypermobile Ehlers-Danlos, like abnormal scarring, hernias, prolapse, that sort of thing. The next is positive family history. And the last feature C is having pain for more than 3 months or recurrent joint dislocations. And then the last criterion is simply that you can't have something else. And so you can't have like another subtype of EDS, that sort of thing. However, when we are thinking about the pediatric population, this criteria is not the best for the pediatric population. And that is because, one, hypermobility decreases with age. And so you may have a 6 on your hypermobility score at age 4, and then that will decrease over time. And additionally, you may not have developed the skin and soft tissue abnormalities. And so when we are thinking about these patients with generalized joint hypermobility, the new framework for diagnosing them is based on, do they have generalized joint hypermobility, that is a Baten score greater than 6, and then do they have other associated complications? And we subcategorize them based on these other complications. And the recommendation is to not diagnose anyone with hypermobile EDS until they are of skeletal maturity or greater than age 18. Regardless, the treatment for hypermobile EDS and generalized joint hypermobility is going to be the same. It is symptom-based. So children that have hypermobility without pain, they don't need any treatment, right? Reassurance, no activity restrictions. Those that have hypermobility with pain, we typically recommend physical therapy, and they may want to consider low-impact activities to minimize pain. And then lastly, if they have joint hypermobility with the core comorbidities, these are things like dysautonomia, amplified pain syndrome, chronic migraines. Those patients should be seen by the appropriate subspecialist and may need lifestyle modifications, physical therapy, and some of them may benefit from cognitive behavioral therapy as well. This last slide here that I'm going to go over is about pes planus. This is flat feet. This is, again, very common in pediatrics. From age 2 to 6, there's about 60% prevalence. And this can be associated with significant pain, not only in the feet and ankles, but also in the back and the neck. And the treatment is very simple. It's orthotics and supportive shoes. And some patients would benefit from physical therapy for this as well. And then I'm going to skip over this portion of amplified pain syndrome since I'm behind time here. And I just want to summarize with my take-home points here. So the history and physical exam are key to assessing a child with joint pain. Arthritis on exam is really defined by swelling and or pain with limited range of motion on exam. And you should consider referral to rheumatology for patients that have inflammatory joint pain that's persistent for longer than 1 month, hypermobility with musculoskeletal pain, or if they have significant dysautonomia, we can help with that as well. And if there are concerns for an amplified musculoskeletal pain syndrome.
All right. Thank you, Dr. Fabricius, with the excellent overview of joint swelling. I guess more of a comment. You talked about scurvy and vitamin C deficiency, and absolutely, I feel like we're seeing that more and more in the hospital, and those kids can be at risk for pulmonary hypertension, especially when they undergo anesthesia. So, I can't believe how many times I've seen it recently, but that's a good point.
Yeah, I've been surprised actually by some patients that have had significant vitamin C deficiency, despite parents saying, well, they're a little picky, but they do eat fruits and vegetables, and they still have significant vitamin C insufficiency. So,
Yeah, that's a big deal.